Hello, my name is Manib Francis, a PGY1 with the Internal Medicine Residency Program at Riverside Community Hospital in Riverside, California. Today I'll be talking about my poster titled LMNA-related Cardiomyopathy, the Telltale Heart. I'll start off by providing a little bit of background on dilated cardiomyopathy. It's the most common diagnosis in patients who undergo cardiac transplantation. Symptoms include those of heart failure, such as shortness of breath, dyspnea on exertion, orthopnea, and lower extremity edema. Other symptoms include arrhythmias, and in severe cases, cardiogenic shock and sudden cardiac death. Idiopathic dilated cardiomyopathy is defined as left ventricular dilation, systolic ventricular dysfunction, and the absence of known detectable causes. It's diagnosed in a large proportion of dilated cardiomyopathy cases and is suggested to be responsible for up to 50,000 hospitalizations and 10,000 deaths annually in the United States. In this report, we describe a rare case of initially unexplained dilated cardiomyopathy that was found to be due to an LMNA gene mutation. We also discuss the importance of family screening in patients with idiopathic dilated cardiomyopathy. Now I'll describe our case. A 44-year-old Caucasian male with no past medical history presented with a 2-week history of progressively worsening weakness, dyspnea on exertion, and orthopnea. Initial examination and workup revealed lower extremity edema and tachycardia, 132 beats per minute. Atrial flutter with a 2-to-1 pattern was seen on EKG. Labs demonstrated elevated BNP in the 1500s, while troponin levels were negative. Initial medical therapy included a calcium channel blocker for heart rate control and a diuretic for presumed heart failure. On further questioning, family history was notable for a father who died at 50 due to heart failure and a sibling who received a heart transplant due to LMNA-related cardiomyopathy. On hospital day 1, transthoracic echocardiogram was performed. If we look at the apical 4-chamber view on the right, we can appreciate severe global hypokinesis as the chambers show little to no change in volume during diastole and systole, most pronounced in the left chambers. We also appreciate bilateral atrial dilation. The left ventricle is dilated with a calculated end diastolic volume of 180 milliliters. The left ventricular systolic dysfunction is also noted with an EF of 8% using the modified Simpson's method. On this day, our patient was essentially diagnosed with systolic heart failure with a reduced ejection fraction. The workup on hospital day 2 is helpful in ruling out different causes of cardiomyopathy. Left heart catheterization demonstrated no significant coronary artery stenosis. Urine drug screen was positive only for THC, and the patient reported only light alcohol consumption. Viral serologies also came back negative. During the evening of hospital day 2, our patient decompensated with hypotension, tachycardia, and respiratory distress. He was intubated, transported to the ICU for ionotropic support, and ultimately required a left ventricular assist device for presumed cardiogenic shock. After gradually regaining hemodynamic stability, our patient was transferred to a quaternary care facility on hospital day 5. At the outside hospital, genetic testing for our patient revealed an LMNA mutation. He was placed on a heart transplant waiting list and discharged to home with an implantable cardioverter defibrillator and guideline-directed medications for heart failure with reduced ejection fraction, specifically an angiotensin receptor neprilysin inhibitor. He was also sent home with antiarrhythmic and anticoagulant medications. Discussion. Our patient was found to have a mutation in LMNA, a gene responsible for nuclear laminin proteins A and C. These proteins provide structural support to the nuclear membrane. LMNA mutations lead to compromised structural integrity and mechanics of the nucleus. Symptomatic patients present with a variety of symptoms, but most often muscular dystrophies, dilated cardiomyopathy, or conduction abnormalities such as atrial flutter, AFib, and heart block. This mutation has high penetrance. 55% of carriers experience cardiovascular death or undergo heart transplantation by the age of 60. Familial dilated cardiomyopathy is a diagnosis made when idiopathic dilated cardiomyopathy is identified in 2 or more closely related family members. LMNA mutations are the most common genetic cause, making up 5 to 8% of all familial cases. While familial dilated cardiomyopathy has been appreciated in 20 to 48% of patients with idiopathic cases, it remains underdiagnosed. Despite having a family history of heart failure-related death and LMNA-related cardiomyopathy, our patient had no previous cardiac workup. Due to the high prevalence of familial dilated cardiomyopathy among those with idiopathic, it is a Heart Failure Society of America Level A recommendation that asymptomatic relatives of individuals with idiopathic dilated cardiomyopathy undergo stepwise screening for familial dilated cardiomyopathy. Screening consists of accurate history, physical exam, ECG, echocardiogram, and creatinine kinase. Cardiac penetrance of the LMNA mutation has been reported to be as high as 85%. Related cardiomyopathy has a young onset and swift clinical progression, often leading to transplant or death. Screening relatives of patients with known genetic cardiomyopathy can help identify patients at earlier or possibly asymptomatic stages of disease. It has been demonstrated that guideline-directed medical therapy for heart failure with reduced ejection fraction, antiarrhythmic medications, and access to devices like ICDs lead to clinically significant risk reduction of mortality from heart failure, sudden death, and overall mortality for patients with dilated cardiomyopathy. This concludes my poster presentation. Thank you for your time.